Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you're probably familiar with this condition, Cushing Syndrome. We're going to be discussing it and much more in this presentation on adrenal gland pathology. This is covered extensively in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, adrenal gland pathology, a little organ, it's very important. You're going to know everything, don't worry. We're going to be discussing Cushing Syndrome, Conn Syndrome, Congenital Adrenal Hyperplasia, yes, that's important, Adrenal Insufficiency, and Pheochromocytoma. So first off, you must know the adrenal cortex. The largest and outermost portion of an adrenal gland is called the adrenal cortex. The adrenal gland is composed of three distinct zones, which include the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona glomerulosa produces mineralocorticoids like aldosterone. The zona fasciculata creates glucocorticoids like cortisol. And the zona reticularis generates sex hormones like testosterone. Now here, we have a baby with Cushing syndrome. The features of Cushing syndrome include a round face, acne, reddish skin, central obesity, and poor muscle tone. When there is too much cortisol in the body, Cushing syndrome develops. The stress hormone, also known as cortisol, is essential for controlling blood sugar and converting food into energy. There are several clinical features of Cushing syndrome, which include muscle weakness, the extremities when cortisol breaks down muscle for gluconeogenesis may be present, leading to small muscles. Moon faces can be present, buffalo hump, truncal obesity with high insulin due to high glucose and increased storage of fat, hypertension, osteoporosis, immunosuppression, and abdominal striae due to impaired collagen synthesis with skin thinning. Many symptoms. Diagnosis of Cushing syndrome is made by checking for increased 24-hour urine cortisol levels. Causes of Cushing syndrome include exogenous corticosteroids because they produce bilateral adrenal atrophy. You'll see that. Steroids, which reduce the release of adrenocorticotropic hormone, which results in a negative feedback. Primary adrenal adenoma, hyperplasia or cancer are other causes that result in atrophy of the unaffected adrenal gland. Pituitary adenoma that secretes ACTH, or paraneoplastic adrenocorticotropic hormone secretion from diseases like small cell lung cancer. Both cause bilateral adrenal hyperplasia. Dexamethasone, which is a cortisol analog, at high doses prevents a pituitary adenoma from producing adrenocorticotropic hormone, which will actually lower the cortisol levels. Cortisol levels continue to be elevated because dexamethasone does not stop a small cell lung cancer from producing ectopic adrenocorticotropic hormone in that scenario, right? I'll say that again. If the patient has increased ACTH due to a small cell lung cancer, dexamethasone is not going to stop it. And here we have a patient with Cushing syndrome. Note their facial appearance. And this is 3 months after therapy with inhaled fluticasone propionate. Interesting. And here we have various panels showcasing histopathology and immunohistochemical staining for ectopic Cushing syndrome caused by a neuroendocrine carcinoma of the mesentery. And here we have various images of radiology, gross images, and microscopic images from a mass that was obtained from the right adrenal gland. It's positive for aldosterone imaging, and in certain panels we can see the cut sections, and the path showed adrenal cortical adenoma with Cushing syndrome. Now let's talk about another important syndrome, Conn syndrome, which is a rare disorder. Since it's rare, it's common on tests. Conn syndrome is a rare disorder known as primary aldosteronism. Conn syndrome is brought on by an excess of the hormone aldosterone, which regulates the levels of sodium and potassium in the blood. Conn syndrome presents as hypertension, metabolic alkalosis, hypokalemia, and hypernatremia. In the distal tubules and collecting duct, aldosterone enhances potassium and hydrogen ion secretion and sodium absorption. Increased absorption of sodium expands plasma volume, leading to hypertension. Adrenal adenomas are the most frequent cause of Conn syndrome, but sporadic adrenal hyperplasia and adrenal hyperplasia are less frequent causes. Conn syndrome is characterized by high aldosterone and low renin, where high blood pressure downregulates renin via negative feedback. On the other hand, renin-angiotensin system activation, such as renovascular hypertension or congestive heart failure, is associated with secondary hyperaldosteronism. High levels of renin and aldosterone are defining characteristics of Conn syndrome. Now, this is important. Congenital adrenal hyperplasia, a group of hereditary diseases affecting the adrenal glands, which are a pair of walnut-sized structures above the kidneys, is known as congenital adrenal hyperplasia. Congenital adrenal hyperplasia is due to the excess sex steroids with hyperplasia of both adrenal glands. The most common cause of congenital adrenal hyperplasia is inherited 21-hydroxylase deficiency. Aldosterone and corticosteroids are made possible by the enzyme 21-hydroxylase. When an enzyme is lacking, steroidogenesis is primarily diverted toward the creation of sex steroid, which does not require 21-hydroxylase. lack of negative feedback from increased adrenocorticotropic hormone secretion brought on by the cortisol deficiency causes bilateral adrenal hyperplasia. Clinical features of congenital adrenal hyperplasia include hyperkalemia, salt wasting with hyponatremia, hypovolemia due to a lack of aldosterone, clitoral enlargement in women, precocious puberty in men, and hypotension. Now let's talk about adrenal insufficiency. Adrenal insufficiency is commonly known as Addison's disease, which is a rare disorder that develops when the body does not generate enough of specific hormones. Waterhouse-Friderichsen Syndrome is a group of symptoms caused when the adrenal glands fail to function normally that can cause acute insufficiency. Features of Waterhouse-Friderichsen Syndrome include hemorrhagic necrosis of the adrenal glands, which is typically brought on by DIC in young children who have Neisseria meningitidis infection. And hypotension is made worse by cortisol deficiency, frequently resulting in death. Chronic adrenal insufficiency, or Addison's disease, as it is commonly known, is brought on by the gradual loss of the adrenal glands. Common causes of Waterhouse-Friderichsen syndrome include autoimmune destruction, which is the most common cause in the West. Tuberculosis is also a common cause in the developing world. And metastatic carcinoma, such as cancers arising from the lung. Symptoms of Waterhouse-Friderichsen syndrome include hypotension, hyponatremia, hypovolemia, hyperkalemia, weakness, vomiting, blah, diarrhea, and hyperpigmentation. Hyperpigmentation is due to opiomelanocortin, POMC, being increased and adrenocorticotropic hormone byproducts stimulating melanotic pigment production. Now let's talk about the adrenal medulla. The adrenal medulla is the innermost part of your adrenal gland. The adrenal medulla hormones include adrenaline and noradrenaline. The adrenal medulla is the primary physiological source of catecholamines and are made up of neural crest-derived chromatin cells. Here we have a picture, a very old school picture, right? Because the adrenal gland hasn't changed in millions of years, showcasing the capsule, zona glomerulosa, fasciculata, reticularis, and importantly, the medulla. Speaking of which, let's talk about pheochromocytoma, a particular kind of neuroendocrine tumor known as a pheochromocytoma develops from chromatin cells. To the right here, we can see the histology on a pheochromocytoma. Chromatin cells are located in the adrenal glands and create hormones that the body requires. Clinical features of pheochromocytoma results from elevated serum catecholamine levels. Clinical features of pheochromocytoma include perspiration, tachycardia, palpitations, headaches, and episodic hypertension. Increased 24-hour urine production and serum metanephrine levels are used to diagnose pheochromocytoma. Medical excision is used as a treatment of choice. When the tumor is manipulated, catecholamines may leak into the bloodstream. An irreversible alpha blocker called phenylbenzylamine is given preoperatively to stop a hypertensive crisis, right? This is a pre-treatment just in case there's leakage of those products. Pheochromocytomas often follow the rules of 10, the rule of tens. 10% are bilateral, 10% are familial, 10% are malignant, and 10% are located outside of the adrenal medulla, such as bladder wall or organ of Zuckerkandl, organ of Facebook at the inferior mesenteric artery root. Pheochromocytoma is associated with other medical conditions such as von Hippel-Lindau disease, neurofibromatosis type 1, and multiple endocrine neoplasia types 2A and 2B. And with that, you completed a very important presentation. There's a lot of integrated systems here and a lot of classical presentations and a lot of rare diseases. So this is highly testable. But I know you got this. I believe in you because you've been doing such a great job. Keep up the good work, and I'll see you later.